We'll move on here to some injuries of the distal lower extremity. And there's only two bones in the distal lower extremity, the tibia and the fibula, so there's really not a whole lot of injuries that can happen. So it's just the tibial stress fracture, which is a really common injury. If you know what a stress fracture is, it's pretty obvious what a tibial stress fracture is then. And then the tibial and fibular fractures. So we'll do a quick anatomy review, and then we'll move on to our injuries. So we have two bones in our distal lower extremity, the tibia, which is the major bone that you feel, it's your shin bone, and then the fibula, which is the smaller bone, it's more for support, and it's lateral. So the way I remember it, L is in the word fibula, and L means lateral, which this is lateral, this is the right lower leg. L for longer, and it is longer, and L for little, because it's smaller. So the tibia has a medial condyle and a lateral condyle. The medial condyle and lateral condyle are both consistent with the joint space in the knee. The medial condyle is one of the insertion points for the medial collateral ligament of the knee. And then the fibula has a head, and the head of the fibula is the insertion point for the lateral collateral ligament of the knee. As you progress distally, the medial malleolus of the tibia is the prominence of your ankle on the medial side, and the lateral malleolus of your fibula is your lateral ankle prominence. The vasculature, as with anything below the diaphragm, comes from the abdominal aorta. The abdominal aorta bifurcates into both left and right common iliac arteries. The common iliac then bifurcates into the internal and external iliac arteries. The internal iliac arteries provide the vasculature to the abdominal viscera. External iliac artery provides vasculature to the lower extremity. So once the external iliac comes through the inguinal ligament, then it just changes name to the common femoral artery. Common femoral bifurcates into deep femoral, which supplies the muscles and the bone of the thigh, and then it also gives the superficial femoral artery, which is the also known as just femoral artery. So common femoral gives deep femoral and superficial femoral. And superficial femoral progresses down to the lower leg. When it emerges out of the adductor canal, right before it goes down into the knee, it becomes the popliteal artery. Popliteal artery progresses down behind the patella. It's the artery that's endangered when you have a knee dislocation. And once it comes out of the knee, it splits off into anterior tibial and posterior tibial. Posterior tibial gives off a perineal branch. So popliteal, anterior tibial, posterior tibial, and perineal arteries are the arteries that are at danger when you have a tibial fracture. And posterior tibial progresses down and supplies the foot. The nerves, so all of the nerves of the lower extremity come from the lumbosacral plexus. Mostly for the lower extremity, it's just, for the distal lower extremity, it's just going to be nerves coming from the sciatic nerve, and that's L5 through S3. And the sciatic nerve is only sciatic for a little while, and then it splits into common perineal and tibial. There's really not many places where you can be injured as far as the nerves when you have a tibial fracture, so this should be relatively apparent. Tibial stress fractures. So stress fractures are primarily seen in athletes after significant increases in physical activity. So who would we see this in? We would see this in soccer players, basketball players, dancers, track and field players, once they get back into their sports. So, you know, those are only seasonal sports. So for instance, you've got a track and field starts in the spring. Your track and field player has probably been relatively maybe sedentary over the winter. Now they're getting back into track and field practice, and they're running 4, 5, 6 miles a day. Boom, stress fracture. Remember, your bones, just like your muscles, have to take time to strengthen up. If you were to go bench press 200 pounds without without having worked out for the last 6 months, you'd pull your muscles. You'd have a lot of pain in your muscles. Same thing with your bones. If you put a lot of stress on your bones after not having done that for a while, you'll get a stress fracture. Stress fracture is just the bone equivalent of a muscle pull. I don't know if that's the best analogy, but you can think of it the same way because they kind of come on the same way from the same reasons. So another patient population you see this in is military recruits, and that's because with military recruits, they probably haven't been active, and they go to boot camp, and they're marching 3-4 miles a day, and that's a major risk for a stress fracture. So the tibia is actually the most common place to get a stress fracture. It accounts for about 1/4 of all stress fractures. Other common places to get stress fractures are just other places where you place stress on your bones. So the metatarsals, the fibula, and the femur are other common places to get stress fractures. The risk factors behind tibial stress fracture, apart from the history, which should be somewhat obvious, would be the female athlete triad, and that's simply because with the female athlete triad, you've got, in addition to being an athlete, female athletes are at higher risk for malnutrition, and it's both a cause and effect factor. So there are females, because they're at higher risk of eating disorders, some anorexic patients will engage in excess physical activity, and they're not getting sufficient nutrients, so they're both hypocalcemic, or they're dissolving their bones, and they're engaging in excess physical activity. So you got the two things right there. The amenorrhea and the osteoporosis are more subsequent from the eating disorder. So those aren't necessarily causing the stress fractures, but the eating disorder, because you're getting less nutrients, you're getting less calcium, female athletes are going to be at higher risk. And then just being female in general puts you at a higher risk for stress fractures. The female bones, just like the female muscles, are less strong compared to the male muscles and bones. So that's just a rule of thumb. And then smoking and drinking have been also linked to stress fractures. The symptoms for stress fracture are going to be pain with ambulation and focal tenderness. And the focal tenderness is really key here. So one of the things that you want to differentiate this from is things like tendinopathy or something called medial tibial stress syndrome. And with medial tibial stress syndrome, you're going to have a more diffuse pain, whereas with a tibial stress fracture, you're going to have a localized point tenderness. You're probably not going to see swelling with the stress fracture. Swelling is something that you're going to see more with gross fractures. Stress fractures are just tiny little hairline fractures, as they're sometimes called. You're actually not even going to see the fracture initially, and so that goes into diagnosis. So the best initial diagnostic test is indeed an X-ray over the affected area, but if the symptoms have only been around for a few days or a week even, you're probably not going to see anything on X-ray because these fractures are so small, they're not going to be picked up by the X-ray. When do you pick them up with the X-ray? You'll pick them up after the healing has taken place. So after about 2 weeks, you'll probably see some calcification around where the stress fracture was. But at that point, there's no stress fracture anymore. It's healed. But you will see some calcification from the healing. So you should get an X-ray initially, and while you're doing that, you're kind of you're doing two things really. You're ruling out a gross fracture, and you're also kind of diagnosing the stress fracture, because with stress fracture, we know that there won't be anything abnormal on the X-ray. So not only will you have the typical history, the typical symptoms of stress fracture, but you'll also have a normal X-ray. we should repeat the x-ray in 2 weeks, and in 2 weeks we should see an abnormal x-ray, which would be the calcification over the affected site. The treatment here is just rest. So 4 to 12 weeks of rest, generally rest until the pain has gone away sufficiently. Pneumatic compression devices or bracing can be useful for healing, and orthotics can be useful for prevention of stress fractures. And so particularly in runners, it's useful for them to have really good foot support in their shoes. That can reduce the risk of stress fractures, and that's more for metatarsal stress fractures. But in general, it's really important to advise your patients to if they're in like track and field, or if they're doing running, training for a marathon, important to advise them to make sure they've got good shoes. Okay, so this is a normal tibia fibular x-ray, and this is in a child. So you know it's in a child because you can see the growth plates here on both ends. So here's your actually, yeah, okay. So here's your tibia, medial, lateral here. So here's your head of the fibula, and then going down here, your medial malleolus and lateral malleolus. Okay, and here's an adult. So the growth plates are calcified. So this is a tibial stress fracture. Now these are really, really difficult to pick up on, and this is magnified, so it's easier to see it. If you're looking at just if you were looking at something like this, it would be even harder to see it. So a lot of times you're going to have to look really closely to diagnose these. And it helps that you know where the pain is, so you know where to look, but you have to look really closely, and all you're looking for is just a little bit of calcification over where the pain was. And it's right here. It should be a somewhat linear line. I mean, it should be parallel to the bone. So right here, this is where your stress fracture was. It's healed. This is the calcification. This one's a little bit more obvious. This was probably a more severe stress fracture. So here you see it right here. And then here, this one's a good one because you see that this is a fracture of both a stress fracture of both the tibia and the fibula. So you have your fracture here and here. And you also have a stress fracture here and here. So you've got a calcaneal stress fracture as well. Okay. Now moving on to the tibial and fibular fractures. So like any fracture, the general cause is a high energy trauma, so motor vehicle accident, getting hit by a car, gunshot wound, or a lower energy trauma in maybe an athlete, or ground level fall in a patient that's older and has osteoporosis. Like any fracture, there's an increased risk with osteoporosis or age. The symptoms are going to be pain and swelling. We tend to see swelling with the tibial or fibular fractures just because it's a more severe injury. And most of these patients are going to be unable to ambulate. In the case of fibular fractures, this is really the only exception. They may be able to ambulate but it would be with pain. And that's just because the tibia is where the weight is being placed. The fibula is just a bone for support. So they may have some pain, they may have some weakness with ambulating, maybe a limp, probably a limp. But some patients with just isolated fibular fractures may be able to walk. So an inability to ambulate is not necessarily always a sign of tibial or fibular fractures, just most of the time. So pain and swelling, sometimes inability to ambulate, most of the time. Physical exam, you're going to see pain with passive motion, swelling. You'll probably see gross abnormalities just because the lower leg is such a small area. You may see some angulation, especially if you have a displaced fracture. Look for ecchymoses. That's going to indicate vascular damage. Look for edema. Look for point tenderness. Also look for any kind of neural injury. So you're looking for numbness over the foot, over the leg. And another thing that you want to look for is a knee effusion. It's very common with tibial fractures to also have a concurrent knee ligament tear. And the reason for that is when you have a break, particularly of the tibia, it's going to pull the tibia down. And when you pull the tibia down, you're also pulling the medial collateral ligament down. Same with the fibula. If you're pulling the fibula down, you're pulling the lateral collateral ligament down, and that can lead to a tear of the ligaments. You also want to rule out compartment syndrome, and compartment syndrome would be caused from just the compression. And so compartment syndrome is, if you're looking at a percentage basis, is not common with tibial and fibular fractures, but the consequences of compartment syndrome being undiagnosed are severe. We're talking amputation severe. So you want to make sure that it's not there. So what you're going to do is just assess the sensation over the leg and the foot. The common perineal nerve is the one most frequently affected. But apart from the sensation over the leg and the foot, compartment syndrome can also be suspected based on discoloration of the extremity and maybe some crepitation if you palpate the extremity, as well as pain. And you shouldn't have, with a fibular or a tibial fracture, you shouldn't have pain over an area that's not right next to the bone. So if you were to palpate like the gastrocnemius muscle, that shouldn't be severely painful. With compartment syndrome, it would be. For diagnosis, the best initial diagnostic test, as with any fracture, is going to be an X-ray over the affected site. Of course, here that's going to be the tibia and fibula. And the treatment for tibial and fibular fractures are generally going to be surgical. So you want to reduce the limb as best as you can in the ED, but you want to get an orthopedic consult in most cases. The only real exception is going to be an isolated fibular fracture, but you're still going to want to get an orthopedic consult. But an isolated fibular fracture is probably the only major fracture of the lower extremity that won't require surgery. So here's a tibial fibular fracture. So this would be probably a patient that got hit by a car, and this was the line of force right here. It's very frequent to see both of these happening in unison. Okay, now this one's important. So I want to take some time to talk about this one. So this is another fracture that's probably not going to need surgery, but this is a toddler's fracture. A toddler's fracture tends to happen in kids around 9 months to 3 years of age that are already walking. And the important thing behind toddler's fracture is knowing that it's probably not child abuse. So a toddler's fracture is a non-displaced, either oblique or spiral fracture that happens in a younger kid. And it's easy to jump to the conclusion that, oh, this is a spiral fracture, it's got to be child abuse. And for the most part, when you see spiral fractures, it may be child abuse. It probably is child abuse, but this one is an exception. The leg is a common place, the foot is a common place to get stuck, and with a kid they might be twisting around, and their bone is not, the bones are not quite strong enough to withhold some of that force. So it's possible to get a spiral fracture without being abused. And if you're going to get a spiral fracture in a kid without abuse, this is the place where you're going to get it. So do not jump to the conclusion that it's, if you were to have a spiral fracture of the humerus, probably abuse. But if you have a spiral fracture of the tibia, do not jump to the conclusion of abuse. And I would imagine that the USMLE could throw this at you, where one of the answer choices is report it to Child Protective Services. No, what you want to do, if a kid has a tibial fracture, and you can, some physicians consider this to be a stress fracture just because it's such a minor fracture, but this is more of a just regular old fracture. But what you want to do if you have a child with a toddler's fracture, what you want to do is get a skeletal survey. So you'll be looking for other fractures. If you see other spiral fractures or fractures that are in different stages of healing, then yes, you'll call Child Protective Services. But if you just have an isolated toddler's fracture, there's no need to call Protective Services, because this is a common injury in children who are starting to walk. So this is the one spiral fracture that is not by itself indicative of abuse. So the major differential here is just differentiating from non-accidental injury. The injury tends to be not witnessed by the parent, and what I would do if you see this is a skeletal survey. Treatment here is generally going to just be casting. Okay, so here's another tibial fracture. This one is comminuted. So you've got an oblique fracture here, and then if you look closely, you can see that you've got some cracks here too. Here's another tibial fracture, oblique. And here's another tibial fracture. And then here's an isolated fibular fracture. So this patient might be able to walk with some pain. And that's it.